So, thank you very much for joining us. We're from Sheffield Teaching Hospitals. We'll just quickly introduce ourselves. My name is Carl Brennan, I'm one of the anaesthetic consultants there.
My name's Tim Sands. I work in the service improvement team as an improvement facilitator at Sheffield.
My name's Caroline Eadson. I also work in the same team as an improvement facilitator. I'm an occupational therapist by background and now work in improvement full-time.
And I'm Paul Griffiths. I'm a programme manager in service improvement, and for this session today we've got a few slides that Carl will go through, and he'll talk through some of the the basics of our programme of improvements in the surgery. And then we will play the game, which is interactive, and we'll do that. And then we've got a few more slides, but we'll give small groups, so obviously we'll not, all the slides are in the app, so you can access them all, but we might not actually go through them all because we don't want to death like PowerPoint and all that.
So, and we hope it'll be quite interactive so you can actually ask questions and learn about your own experiences. So, for the discerning amongst you, this is not Sheffield Teaching Hospital, but this is the Royal Albert Hall. And we show you that because when it's full, it holds 5,500 people, which means that the staff in our organisation could fill this 3 times over. It's basically a lot of people and a lot of capability, but more importantly, we think of it as a lot of talent and a lot of ambition. What we're trying to do is align that sort of ambition of those people in that room, or the equivalent of that room, to best serve the 36,000 patients who undergo elective surgery in our trust each year. And that's what seamless surgery is about. Just to give you another perspective of our organisation, if you like. If you were to line everybody up in South Yorkshire and a few beyond who sort of rely on our trust for their care, you said, hello, nice to meet you, hello, nice to meet you, hello, nice to meet you. It would take you 2 months without stopping to greet them all. It's basically a lot of people, and in this queue are people who need cardiac surgery, neurosurgery, complex spinal surgery, people who develop cancer and need major cancer resections. For most of those people, they have no alternative, there is nowhere else to go. So what we very much describe in our seamless surgery team is that this is not really an option for us. It's not about a choice. We need to make the service as good as it can be because it's not really that patients can go anywhere else. This is a very high-tech sort of technology, but what we're trying to, you'll hear about a couple of innovations, both from playing the game and what we talk about after it. So there have been some innovations in what we do, but what we really realise is that if you want to improve the outcomes for patients, you genuinely do need to consider every single step of the process. You can't just, because theatre utilisation is expensive and matters, you can't just focus on that. You really need to look at every single step of it from sort of referral through to discharge. And that's what we've done in our programme, we believe. And the take-home message, which I genuinely think we all really aspire to, is that seamless surgery is not really to achieve one thing, it's to make the service as good as it can be for patients, but in doing so, making it better for the staff, the people who work for us, and of course to benefit the NHS overall. And I think you will hear examples of actually by using quality improvement, doing the right thing, that you can actually see benefits for everyone involved. Now, this is one of our patients, and we consider patient experience to be an important part of seamless surgery, really, and probably an example of a really bad patient experience is a patient cancellation. So we actually used Janet's experience to help develop a video which just really hammers home what a cancellation means. It's very easy when you work in theatres to just see it as another number, so we don't have time, let's just cancel. So we used her experience to sort of describe what that really feels like. And although it's a 5-minute video, we've just given you a snippet here.
No, it's the full video.
Oh, it's the full video then.
So, yeah.
There you go.
Well, it was going to be quite a big operation. I wasn't sure how long the recovery period would take, how mobile I would be. So obviously I was anxious. You just sort of prepare yourself emotionally and in a practical way, getting the house and everything ready to be immobile for a while.
There was a relief that we were moving forward and progress would be made. But there was anxiety and nervousness because I think that is natural for anyone going into surgery.
A lady who I understand was a manager of the theatre lists and bed allocation came to see me and said, "I'm sorry, but we can't do your operation because we haven't got a bed." And I think I must have gone into shock slightly. I felt faint. I was told the colour drained from my face. I felt clammy and I couldn't at that moment have stood up, for example. I would have fallen to the floor. When I finally went for the operation the 2 weeks later, all the time I was there getting ready, I was saying to myself, you're not actually going to have it. They're going to come and tell you in a minute. And the stress level was very high. And I was quite surprised when they actually called me to walk round to the theatre door. I felt uncared for, somehow as though I didn't matter. It was a bit of a feeling of rejection almost.
I mean, anger is a strange and horrible word in a way, but yes, I did feel, I felt I wanted an explanation. I think I couldn't probably see very clearly at that point that nobody was able to give one. Probably still aren't.
The patient being told that they're cancelled, they react in different ways. Some accept the news, very well, and they understand and they take it very graciously, really, whereas the other response is of anger, of frustration, and I really empathise with that. To deliver such news to a patient of a planned surgery being cancelled is devastating. I've been in this position of senior sister here for many number of years, and I have to say that I don't find the situation any easier at all. Cancelling the procedure today.
Well, the most important cost is the cost to the patient, of course. They've had such an emotional investment into coming into hospital for their procedure. You come in and say, look, I'm really sorry, we can't do your operation. Must be heart-wrenching. Every time we cancel one person's operation, it means we then have to invariably cancel another person's operation. We've lost a slot. You never get that back. So the cancellation story is not just about patients whose operations get cancelled on a day. There's this whole raft of work that's gone on behind, and it's infuriating when the patients don't get their operations.
Okay, so the reason we've shown that video to a lot of people, a lot of clinical staff and non-clinical staff around Sheffield teaching hospitals, and I guess the reason we use that is because although we've got all the data, so we know like 2,000 plus patients cancelled on the day of surgery, a lot more the day before, kind of people have become normalised to those numbers and it doesn't have the same impact. But when you kind of put the numbers with the video, it seems to engage people and get them thinking about some of the challenges and the things that are difficult. So that's kind of one way of engaging people. The other way we try and engage people in some of the work we're doing is kind of a bit more of a fun and interactive way, which is the game. So I think we'll do the game now. So I'll just hand over to Tim and Caroline who will explain a little bit about how that works and then we'll play that.
Yeah, so I think with a number of people, I think we're probably going to have 3 games, maybe 1, 2, and maybe a third one there. We'll kind of move you around maybe. But so basically the game, hopefully it's fairly straightforward, a bit of fun, but you pick a character. You then take it in turns to move that character around the board. So the first person will move their piece onto step 1. They'll take a card, read it out to the rest of the group, and then follow the instructions on the card. You'll all have a turn on step 1 and follow the instructions. And at the end, you'll see you've got a little flip chart in front of you, which is a number of weeks it's taken for you to have your surgery. So every time that every player's had a go, you turn that to the next week, and we'll see how many weeks it takes for people to get around. Does that make sense to everyone?
You need to have a wisdom tooth surgically removed.
ERS goes straight to step 3. So we need to turn to week 2 now.
It's the same, they go straight to step 6. Ring to rearrange, stay on step 6.
Third on list, go to step 8.
So could we just ask you to share some of your perhaps thoughts and experiences as how it felt for you as a patient in this situation?
It just give you a taste of how it must feel to get that letter and to think, you know, again, you know, so I think that's really helpful to bring to us, yeah.
Yeah.
And all the scenarios were familiar. All of it is real.
And these scenarios are real, and we created the game, but we didn't create the scenarios at all. And these are even down to people not being able to make their appointment because the car park's full, and letter clinic running late. I heard somebody say, so you had to leave before, you couldn't stay. These are very real things that do happen. So yeah, people can relate to them because, we're all kind of patients as well, and families who've been in this situation, so everyone kind of experiences this.
Does this feel like a system that's sort of designed around the patient?
Yeah. It's designed by function, isn't it, rather than...
And is that kind of how we think lots of our organisations work?
It's difficult because we've designed it to try and get as many patients through as possible, so we cram out patients full, we overbook clinics, because then if they're DNAs, at least we've got the right number. We overbook clinic, which means we're late to theatre. We're doing it to try and cram as many patients through the system as possible, but in doing so, we're creating a huge amount of inefficiency.
And rework.
So how do we do less to do more? Because it feels that we're in this inescapable cycle.
So was there anything within that which kind of felt like, because although it kind of feels like a frustrating thing to do and it kind of gives you that experience as a patient, what were the things that you kind of came across that perhaps some of the improvements, or some of the things where you sort of skipped forward and skipped some of the steps? Did anybody have anything like that?
E-referral?
Yeah.
E-referral, yeah.
That skipped 3 steps, I think, for me.
Yeah.
And
texting.
pre-op assessment as well.
Yeah.
That got me through about half the board, I think.
Yeah.
Day surgery. 3 days.
Reminder call.
Yeah, reminder call, so potentially, although it is a game and hypothetical, but potentially preventing a cancellation there. Yeah. Any others?
Text communication rather than letters.
Yeah. Just to try and avoid some of those ones of the letter arriving while you're on holiday in Spain or whatever that one was.
Did anyone get a mention of being able to choose your appointment date? Well, that is another thing, is obviously giving the control to the patients. We often send them a date, don't we, that may or may not work, but we kind of just send them a date. But when they have a bit more control over the date, they tend to have a much reduced DNA rate. And out of interest, when we first looked at this 2 years ago, how many people do you think got through the whole of their journey without any kind of rearranged appointment? It's 1 in 3 it was. And the record of number of some kind of rearranged appointment or cancellations for one patient, do you know?
Yeah.
Well, it was 33. That's an extreme example, but I suppose the point is this is a real scenario. These probably feels a bit unreal when you're playing the game, but for lots of patients, they actually do experience these rearrangements.
And I guess so what we've done in Sheffield for the past probably 5 years is we've been doing improvement work across elective surgical pathways, and we've gradually learned really small scale. So the first team was like one bunch of people in a foot and ankle theatre, and they were working out how could they introduce regional blocks, anaesthetic blocks, to take some steps out of the patient journey. And then they worked out they could do that. Patients didn't need to go to recovery, they could go straight back to the admissions unit, be discharged. Then they thought, we can stagger the admissions, so bring patients in closer to the time of surgery. Then what they realised is if they had an extra anaesthetist to support that process, they could make the list more efficient. Then they thought, well, we can actually treat more patients on this list. And kind of out of all of that, the impact of patient experience. Staff found it better to work on because it was kind of more organised and they were in control of what they were doing. And efficiency is kind of making better use of resources, helping patients through the pathway. Yeah.
I think we'll be touched because this is something we're doing just at the minute at the National Orthopaedic Hospital. But can I just check what the outcomes are? So presumably RTT, theatre utilisation, patient experience, outcome metrics and stuff.
So we've got some slides on that. So I think if we just zip through a few more slides, then there'll be time for any more questions, if that's all right. And I'll show you some outcomes. So as Carl says, this is kind of our seamless surgery programme. So there's a core team of us who work on it, but actually all the work's done out in surgical directorates and we're there to support. We asked patients what they wanted from their elective pathway. This was about 2 years ago. I thought we'd kind of say to patients, once you've been listed for surgery, what do you want? Any ideas what people said? And it wasn't like a hip replacement or anything like that.
They want to be involved in choices.
It's pretty basic actually. These were the key things. Am I fit for surgery and when will it be? So what people wanted was just kind of clear communication of, right, I've got to have an operation. When's the next step going to take place and how will it happen? So as part of the process, we introduced electronic pre-assessment, which some of you kind of went through on that board, and we tested it really small, handful of patients. We had a system that an anaesthetist who worked in our hospital had developed and then commercialised it, but it was free to us because it kind of the IP sat within our organisation, so it made sense for us to use it. And we asked patients what they thought about it. So and we got some really positive feedback. So instead of patients go to outpatients and be listed for surgery and sent away and waiting for a letter to say come for a pre-op assessment, they just walk straight round, do the system. The outcome of that would be they might need some more nursing input or they might be fit to go. If they're fit to go, then they could talk to the specialty there and then and say, right, I'm ready for surgery. And we've had instances where patients have had their operation the next week, so they've been listed and following week they have the procedure. And these sorts of innovations, I guess, kind of form our seamless surgery programme. And that's just some numbers in terms of how we've, particularly around electronic pre-assessment, how we've increased that number of patients going through it. And so obviously it's better, patients don't have to come back for return visits, but it's better for the organisation. You're making nurse practitioners, you're using their skills to see the complex patients and not just do a kind of form with patients who actually don't really need that assessment. And then a little bit about staff. So we've got specific projects like reminder calls, electronic pre-assessment, some scheduling tools, things which we've brought under this umbrella of seamless surgery that we know if people implement these things within their surgical directorates and aggregate them up, it'll be a better experience for patients. But it took us a long time to get to that. So we've spent years and years in service improvement, understanding existing processes, really complex stuff. We looked a lot at national evidence and thought, kind of what can we learn from outside our organisation? So we understood best practice for us in Sheffield, but looked outside. Spent loads of times kind of workshops and all that sort of stuff, bringing people together. Often you'd find that someone in orthopaedic surgery was having all these problems and they didn't realise it was the same as the people in neurosurgery, but they're just working their own sort of clinical specialties from a scheduling perspective, for example, and bringing people together to talk about their challenges and problems. And then what colleague Tim's done a lot of is trying to standardise practice, particularly around scheduling through SOPs, which kind of sounds simple and basic, but actually I guess we found through the process of talking to teams that often people who sat kind of next to each other were doing a theatre list one way and someone would do it a different way, and someone would be planning weeks in advance, someone would be like the day before because the surgeon would come and see them the day before and say, I need to do this tomorrow. So we're trying to get away from that because we know that creates problems for patients, for staff, and creates issues for running lists on the day. We've done a lot of this stuff, obviously engaging teams with this game is a good way of talking to people about this work. And then what we did probably about just over a year ago, 18 months ago, we started the process of thinking, so we know all these bits of good practice and we've got these projects, and as a kind of core improvement team, we're working with all these different people, but how do we kind of bring it together in a way that we feel like we can scale it up across the organisation? So we've got kind of 12 surgical directorates, thousands of staff working in those, 36,000 operations per year. So we're thinking, we need to kind of brand this up and have a way of kind of giving a simple message about those kind of principles of best practice. So we spent a lot of time kind of forming this document. There's some copies of it on the table, and we got a logo and all that, and thought, you know, this is a way of talking about some of the work we're doing. And then we had a big launch event. I'll let Carl talk about
I suppose we were aware that we had lots of little pockets that were working well, but we didn't really have a sort of corporate approach to it. And we actually had a half-day theatre shutdown where we had just shy of 300 people attend this event, which included staff from outpatients, theatre teams, schedulers, and sort of clinical services managers, ops directors, as well as several of the execs, so the medical director, director of strategy, chief exec. This was the first time that some of these people had ever met, really. They're working on the same pathway, but they never really met one another, knew what one another did. So we had this kind of workshop thing where we had our principles, but we wanted to know, well, how is that going to work in your environment? What can we learn from you about in what way your environment is different? And it was this opportunity for these frontline teams to actually speak to the execs that I think they'd certainly not had before, or not easily. And probably best summed up by this quote here about it was a great opportunity to meet, but it was the first time they'd done it for 27 years. So people have been working the same job for 27 years and haven't even met people on there who they work alongside in the pathway. We did this 2 weeks after the Euro 2006, where the Icelander who became famous. And I guess the point of this was that, I don't know if you remember this, but it was one of those moments where people thought, well, it looks really good. If you have a goal and you commit to doing your bit, you can sort of inspire people to get involved. And I kind of thought, well, why don't we do this with our group of people at this launch event? So we did. I wasn't sure. At one stage we thought we'd be the only ones doing that. Went better than expected.
Okay, and so I guess what we've tried to do is take kind of bottom-up improvement work and kind of blend it with some executive leadership and create a framework for improvement that then we've supported directorates with. So since that launch, which was a year ago, we've got a governance framework through a seamless surgery board, but then we've got a working group, and directorates have got their own teams who are working on this stuff and come to us for help with whatever part of the process they need help with. So some areas are fine with EPAC and electronic pre-op, and they do all that. Other areas it's new to them. So the kind of challenges between one surgical specialty and another are different. I guess part of our role is to help them with the challenges that they've got, and then measurement and the things around that to support that. And then this week we've got an awards night on Thursday night, which is kind of when we ask people about what kind of, we asked staff at the launch actually, you know, how do you want to be recognised when you do work and, you know, improve processes and all that, and people kind of said, oh, we want some sort of thank you, would be nice. So we went through a long process of agreeing with our trust to hold an awards evening specifically for this programme of work. So that's this week, and we've got kind of 6 awards and execs coming to present, and about 150 people are going to be there. And it's quite a rare thing. People always want to see, it's nice to say thanks, but to actually create an event that celebrates it, I think it's important. So we will see how that goes. I'll not go through, so these are some of the examples, and they'll be in the slide pack. And then finally, just improving the whole system. So this was a question about metrics, I guess. So we've seen, so that was the launch, so we're kind of a year on, that was last July. We've halved the number of booked theatre lists cancelled, so we've had a big impact in terms of getting organisation, kind of the booking process around lists that we're committing to doing working, so we're not cancelling, booking lists cancelling.
The other thing to say about this, of course, when you reduce the cancelled list, the reduction in the amount of work that admin staff are doing, the rework, is phenomenal. So it does have massive benefits over and above what you just see there.
And so we're treating more patients, so we're treating kind of partly to do with reducing cancelled lists, but also we've reduced on-the-day cancellations as well. So we're treating probably 25 more patients a week, every week for a year. And kind of impact financially, we've seen we were struggling, so this is our kind of inpatient monthly income against target, so obviously if you would be zero if we were breaking even, so we were losing money month on month. We just weren't doing the activity through theatres. That's a consequence of the whole pathway not functioning. Kind of since the launch, we've seen a big increase up to last month. That last month's partly a reflection of an increased target for this year, so activity's still being good, if that makes sense. So we would estimate that kind of since the launch, probably treated about this many more patients through the same resources really, and it's kind of had a positive income impact. We've not looked specifically at 18 weeks, partly because there's a lot of other variables on that, but it's something we kind of talked about with our operations team about how can we demonstrate that impact. But so I think that's probably all. And then there's a slide just I'll flash this up. So we it's kind of just the start really for us. So we know what we've done so far is about getting everything right that we already control and that we've got we're kind of a resource for. And then for the future for our team, we're thinking about all these sorts of things, a lot more into reducing clinical variation. How can we work more with GPs around preassessment, these sorts of things. So kind of...
And the sort of patient outcomes as well, where obviously clinical outcomes are kind of sometimes difficult, but we're trying to sort of include patient experience outcomes and clinical outcomes as part of what we're doing, so that it's not just about theatre utilisation, it's about understanding that the quality of the care we're giving is better. So we're trying to sort of broaden what we do as well as what you've already heard, really.
Okay, that's it.
Has anyone got some questions about either what we've done or their own experience?
The thing that causes my surgeons the most distress and disgruntlement is the scheduling process. So we use Opera, that's the theatre system that we have, which generates average operating times. And when surgeons book cases, they put on a number of minutes that they think the procedure is going to take them, but that's completely disregarded. And the average times are put in, and there's a certain number of minutes that each list has to be booked up to, and it's done by booking clerks who are Band 2 staff. So we quite frequently find that a list may be booked, and then the week before a surgeon will come along and say, no, I can't do those cases in that length of time. Or I must leave this number of minutes in case of an emergency, and things like that. And so the reason I'd be interested in your scheduling SOPs is that we need some way of ensuring that everything is done in the same way and that clinicians are engaged. And my second question is, are your surgeons job planned for a certain number of minutes or hours during the week to do scheduling? Because I will find that unless they are, they will say no, it's not my job plan.
Well, I think the job planning, they tend to be, as far as I'm aware, most of based on the number of PAs for clinical, for theatre time. There will be some administrative time along with that, but that's generic with all the other paperwork. Okay. I think where we've had the most success in terms of what you're describing is this theatre production control meeting, which is a weekly thing. So we routinely look at previous weeks, what actually happened rather than what we thought would happen, as well as looking forward to the next couple of weeks. And I think you just have to have an honest conversation with people and sort of a bit of trust that we say, well, and it's not easy. I work with neurosurgeons, so trust me. But they say something is going to take so long, and I kind of will support that, and maybe even put on an extra member of staff if possible, if it's a high turnover list or something. But we do use the data that's what actually happened to say, well, what happened last week's not acceptable, we need to learn from it. So we've gone from having massively overbooked and underbooked list to having much less variation in the list. And of course, an overbooked list is really frustrating for staff, and they stop kind of engaging with it. And an underbooked list feels like a wasted opportunity, and the staff, well, yesterday was rubbish and today I'm going home early. So by going through that honest sort of production control and doing it properly, really, we have seen a lot of benefits. But the Alturos, which is our equivalent of your Opera, only ever tells you what you've done previously. It doesn't tell you what you're capable of doing. So I think we do try and push the boundaries and say, all right, that takes you an hour and 20 minutes, but that's when we're not really trying. is it achievable to do it in an hour if we put all the resource in and we kind of learn from it? Have you got anything to say about the SAP as well?
Well, I was just going to say about the planning meetings. I think the value in it has been getting, you talk about the booking clerk trying to do it on their own, and then the surgeon coming in at the last minute, actually having those set meetings where we've got a representation of the booking clerks, we've got experts from theatre who know what's actually going to happen on the ground and the staffing that they've got available, and we've got clinical input as well as to how different operations might, how long they might take. Actually bringing all that together in a really structured manner at a set time each week means that we don't have as many of those last minute changes or those overruns.
Only really a couple of weeks for most. I mean, orthopaedic, truly elective work, ideally longer. But even with neurosurgery, which is a very non-elective specialty, we'd still expect most lists to have the bulk of the work already described. And we do challenge people, we do say, we've actually worked quite hard, I think, in building a bit of a rapport between different clinicians. Therefore, you can ask, not in a difficult way, but just ask, is that really achievable? Because the last 6 months you've never done in that time. What is different about that patient?
I'm conscious that we're now running over time, but...
Not quite,
I can answer those two questions quickly. EPAD Pro, it is available, anyone can buy it. You just search for it. If you search on Google, you'll find their website. So they're based in Sheffield. I think only currently we use it, but we've had loads of trusts visit who are interested. The board game is not for sale. We looked into that. You have to fork out loads of money up front, so we've done all this ourselves. But we'll happily share. We don't mind sharing the kind of PDFs of the stuff and all that if people want them. Just our contact details are on. There's like a little one-page book thing, all through the. I guess will be on the app for the stuff today. So there's an email address on the back of that, I think. If anyone's interested in getting stuff for the game, we'll happily email it on. We're not precious about any of it. All right.
Thanks for joining us.
Great.
Thank you very much.
Thank you. Cheers.